Right now, somewhere in your medical chart, there is a number your doctor has been calling fine for years. It's the LDL line on your last lipid panel. After 60, that fine has just been redefined as a danger zone. The new number is 55. If your LDL is anywhere above it and you have any cardiovascular history at all, the latest guidelines say your risk has been quietly underestimated. I'm going to walk you through exactly where 55 came from, why it matters more for you than for anyone in their 40s, and the 4 steps that will get you there. I'm Dr. Richard James. After more than 3 decades in cardiovascular medicine, I have watched the LDL target move from 130 to 100 to 70, and now to 55 for the highest risk patients. For 20 years, the standard was 100. For some patients, 70. The newest guidelines push that down to 55 for the highest risk patients over 60. Almost nobody told you the line had moved. This is not about chasing a number for the sake of chasing it. This is about whether the normal on your last lab report still means what it meant a decade ago. It does not. If you are over 60 with any prior heart attack, stroke, stent, or bypass, your risk is being underestimated, quietly, every single year, by the gap between what your chart says is fine and what the latest guidelines now define as protective. The European Society of Cardiology lowered the target to 55 in 2019. The American guidelines have been catching up steadily over the last several years, with the most recent ACC-AHA cholesterol guidance aligning the highest risk threshold downward. Here's the harder question. It isn't where the number came from, it's where you are now, and how the fine you were told for 20 years quietly stopped being fine without anyone notifying you. Stay with me, because the science behind 55 is more solid than most patients realize. Pull up your most recent lipid panel. Find the line that says LDL. That is the line you should care about most. Not total cholesterol, not the ratio your doctor circled in pen, not the number your father used to brag about. LDL. Most viewers over 60 have been tracking the wrong line for years. The lipid panel has 4 numbers that matter: total cholesterol, HDL, the so-called good cholesterol, triglycerides, and LDL, the so-called bad cholesterol that actually deposits into arterial walls. Some labs are now flagging a 5th number, non-HDL cholesterol, as the better risk predictor. Total cholesterol is the least useful number on that page. It mixes your HDL, which is protective, with your LDL and other particles, which are not. A patient with high HDL and high total can look identical on paper to a patient with low HDL and high LDL. Only one of those patients is in danger. The single number predicts almost nothing on its own. LDL is what actually drives plaque formation. The mechanism is straightforward. LDL particles slip into the inner lining of your arteries, oxidize, and trigger an immune response that calcifies into plaque over years. That plaque is what narrows the artery. That narrowing is what causes the heart attack. That narrowing is what causes the stroke. The number on your lab report is the rough proxy for how aggressive that process is right now. The lower the number, the slower the process. That is why the target keeps moving downward as we get more data. Now here's the part most people miss entirely. The LDL target depends on which category you fall into. There is primary prevention, which means you have not yet had a major cardiovascular event. There is secondary prevention, which means you have already had one: a heart attack, a stroke, a stent, a bypass, or significant arterial disease detected on imaging. The new 55 target is aimed primarily at secondary prevention. If you have ever had a cardiac event, the current guidelines say your LDL should be below 55, not 70, and certainly not 100. The 55 target is aimed at you specifically. Your subgroup matters more than the headline number. This is exactly where most people make a critical mistake. They look at the average target and assume it applies to them. The science says it does not. Here's where it gets really interesting. The line on your lab report that actually predicts your stroke risk has been moving downward, year after year, while the conversation between you and your doctor stayed frozen at a number that was set when you were in your 50s. If you're sitting there wondering whether you're already safe at your current number, that is exactly the right question to ask. It is the question we are about to answer. First, you need to understand where 55 actually came from. In 2015, A trial called Improve It changed how the field thinks about LDL. It compared statin therapy alone against statin therapy combined with ezetimibe in patients who had already had a cardiac event. The combined group got their LDL down to 54. The statin-only group settled around 69. Both groups were already at what most doctors at the time considered an acceptable target. The trial followed more than 18,000 patients for 7 years. The result was clear. The lower LDL group had fewer heart attacks, fewer strokes, fewer hospitalizations. The benefit didn't disappear at the lower number. It compounded. That single trial broke a 30-year-old assumption. Cardiologists had spent decades arguing that pushing LDL below 70 was either pointless or potentially harmful. Improve It showed otherwise. Then came FOURIER in 2017. This trial pushed LDL even lower, into the 30s and 40s, using a new class of injectable medication called PCSK9 inhibitors. More than 27,000 patients participated. The follow-up was shorter, but the signal was unmistakable. Cardiovascular events kept dropping. Stroke risk dropped. Heart attack risk dropped. No safety floor appeared. Patients with LDL values below 30 did not show increased adverse events compared to those at 50 or 70. ODYSSEY Outcomes followed in 2018, with a different PCSK9 inhibitor and a different patient population. Same finding. Lower LDL, lower events, no harm signal. So now you have 3 large randomized trials, more than 70,000 patients combined, all showing the same thing. Lower is better. Nobody has yet found a floor. Translate that into something you can use. If your post-event LDL has been hovering at 90 for years, the data says you have measurable residual risk that an LDL of 55 would meaningfully reduce. The trials counted heart attacks and strokes that did not happen in the lower LDL groups. That is the data the European Society of Cardiology acted on when they lowered the target to 55 in their 2019 dyslipidemia guideline. It is the data the American College of Cardiology and the American Heart Association have been steadily incorporating into their own updates. This is not opinion. This is not one expert's preference. This is decades of randomized trial evidence, accumulated patient by patient, until the picture became impossible to ignore. Here's what 55 actually represents. It is the lowest target where the trial evidence has consistently shown benefit, with no harm signal yet detected, in patients who have already had a cardiovascular event. Could the target eventually drop lower? Possibly. The science isn't finished. For now, 55 is the line where the evidence is strongest and the safety record is cleanest. Now I know what some of you are thinking. Lower is not always better in medicine. We have been burned before by lower is better hypotheses that turned out to be wrong. The difference here is the volume of evidence. 3 major outcome trials, multiple meta-analyses, more than a decade of post-hoc analysis, all showing the same direction of effect. So that's where 55 comes from. Now we have to talk about something more uncomfortable. Why your old number was never wrong, just outdated. Here is the part that frustrates me the most as a doctor. The standard for what counts as a safe LDL has dropped twice in the last decade. The conversation with patients has barely changed. Most patients over 60 are still being measured against the number their doctor learned in residency. Most doctors are too busy, too overworked, or too cautious to recalibrate that conversation in real time. You did not fail. The science moved, and the system did not always move with you. There is a difference between those two things, and I want you to feel it clearly. For 20 years, you were told that 100 was fine. At the time, that was the standard. You ate the oatmeal, you walked the steps. You took the statin if your doctor prescribed one. You hit the 100 target your doctor circled. You assumed the conversation was finished. It wasn't. Sometime in the last decade, the target moved to 70 for high-risk patients. You may not have been notified. Then it moved again, to 55, for very high-risk patients in secondary prevention. You almost certainly were not notified. Picture a representative patient, someone like Carol, a 72-year-old retired librarian. She had a small heart attack at 68. She has been on a moderate-intensity statin ever since. Her LDL has hovered in the 80s for 4 years. Every annual visit, her cardiologist has glanced at the number, said, "Looking good," and moved on. Carol has assumed she is exactly where she needs to be. She is not. Not under the current guidelines. Not for someone in her risk category. That is the gap I am trying to close. Not because Carol's cardiologist was negligent. The previous standard was 100, then 70. The system caught up to the science slowly. In busy practices with 12-minute visits, the recalibration conversation rarely happens. You were doing your best with the number you were given. Now you have a new one. That is not a failure. That is an upgrade. Stay with me, because this next part could save your life or someone you love. The path from your current LDL to 55 has 4 steps, and they are not what most patients assume. Step 1 is lifestyle. Soluble fiber, weight loss, reducing saturated fat, and a Mediterranean-style eating pattern can drop your LDL by 10 to 20%. The data is solid. Consistent dietary change is real medicine, not folklore. In practical terms, that means oats, beans, lentils, the inner flesh of apples and pears, and ground flaxseed, the foods rich in soluble fiber that physically bind cholesterol in your gut. It also means cutting back on the saturated fat in butter, cream, fatty red meat, and full-fat cheese. None of this is exotic. None of it is new. It is just rarely done with the consistency the trials required. It is also rarely enough on its own once you're over 60. Your liver becomes less responsive to dietary changes as you age. The 20% drop a 45-year-old gets from a Mediterranean diet often becomes a 10% drop at 70. Lifestyle is the foundation. It is not the ceiling. Step 2 is statin optimization. This is where the biggest single move usually happens. Most patients over 60 are on a statin, but a surprising number are on the wrong intensity for their risk category. A moderate intensity statin like simvastatin 20 mg or atorvastatin 10 mg lowers LDL by about 30%. A high intensity statin like atorvastatin 40 to 80 mg or rosuvastatin 20 to 40 mg lowers it by 50% or more. If you are in secondary prevention and your LDL is still above 55, the first question is whether your statin intensity matches your risk. Often, it does not. Often, the prescription was written 10 years ago, when the target was higher, and nobody has revisited it since. If muscle aches have been a problem, the answer is rarely to give up entirely. Switch agents, lower the dose, try every other day dosing, or move to step 3 sooner. There are options. Most patients who say they can't tolerate statins have only tried one statin, at one dose, for a short time before stopping. Step 3 is ezetimibe. This is a low-cost, generally well-tolerated second medication that blocks cholesterol absorption in the gut. Added to a statin, it drops LDL by another 15 to 20%. The Improve It trial, the same one I mentioned earlier, was the trial that proved adding ezetimibe to a statin produced fewer cardiovascular events than the statin alone. Many patients hit the 55 target right here at step 3. A high-intensity statin combined with ezetimibe gets a typical secondary prevention patient from an LDL of 90 down into the 50s. Step 4 is for the patients who can't reach 55 with the first 3 steps. PCSK9 inhibitors are injectable medications that drop LDL by an additional 50 to 60% on top of optimized statin therapy. They are typically self-administered as an injection every 2 weeks. Bempedoic acid is an oral option for patients who cannot tolerate higher statin doses. Both are reserved for very high-risk patients with significant residual LDL after the first 3 steps. Insurance coverage has improved over the last several years, but the path still requires a knowledgeable cardiologist willing to advocate for the medication. These step 4 medications are not the first thing to ask for. They exist because the first 3 steps don't always get a very high-risk patient all the way to 55. There is a tool for the gap. Before I give you the exact protocol you can take to your doctor on Monday, there's something you need to understand first, and it's the part that changes how this conversation should go. The most common question I get is whether an LDL of 55 is dangerously low. People hear the number and immediately think, my brain needs cholesterol. Won't I lose my memory? The fear is real. The science does not support it. The Ebbinghaus cognitive substudy, attached to the FOURIER trial, specifically tracked memory, attention, and processing speed in patients pushed to LDL values in the 30s. It found no cognitive harm, none. The patients on the lowest LDL values performed identically on cognitive testing to the patients with higher LDL. There's a biological reason for that result, and it's worth understanding. Your brain manufactures its own cholesterol. The cells that make up your neurons synthesize cholesterol locally, because cholesterol cannot easily cross the blood-brain barrier in either direction. The LDL circulating in your bloodstream is not the cholesterol in your brain. They are two separate pools, regulated by two different systems. When you lower your circulating LDL with a statin, with ezetimibe, or with a PCSK9 inhibitor, your brain doesn't notice. It continues making the cholesterol it needs locally, exactly as before. The LDL drop happens in your blood vessels, where it actually matters. There is a real distinction worth making. The 55 target applies to risk-stratified secondary prevention. It is not a target for healthy 50-year-olds with no history. It is not a target for primary prevention without significant risk factors. The aggressive aim is for the people who have already had an event, because the data shows they benefit most. If you are not in secondary prevention, your target is different. Your conversation with your doctor is different. For the patients this video is aimed at, the cognitive fear simply isn't supported by the evidence. Here is the synthesis, the point of this entire video. 55 is not a magic number. It is the lowest target where the trial evidence has consistently shown benefit without harm in high-risk patients. Whether you reach 55 or 65 or 70 matters less than whether you and your cardiologist are actively moving your number downward using the right tools for your specific subgroup. The number is a direction, not a finish line. If you are in secondary prevention and your LDL has not been actively reviewed and adjusted downward in the last 12 months, this is the conversation you have not had yet. The question is not whether you are at the target today. The question is whether you and your doctor are actively working toward it, with the right tool from the right step on the 4-step ladder. If the answer is yes, you are in good hands. If the answer is no, or if the answer is, I don't know, then you have a phone call to make this week. By the end of the next 90 seconds, you will know exactly what to ask for. Here is exactly what I want you to do. Tonight, pull up your most recent lipid panel. Find the LDL line. Write the number on a sticky note. Put that sticky note on your refrigerator so you see it every morning. This week, call your cardiologist's office. Ask for a 20-minute appointment specifically about LDL targeting. Use that exact phrase, LDL targeting. It signals to the scheduling staff and to your doctor that this is a focused conversation, not a routine annual visit. At the visit, ask 3 questions. First, given my history, am I in secondary prevention? Second, what is my personal LDL target under the latest guidelines? Third, what is the next step in the 4-lever protocol if I am not at target yet? If you are already at or below 55, ask whether you should continue your current regimen and what the maintenance plan looks like. Write targeting 55 in the comments below. That single phrase tells me you've decided to have this conversation with your own doctor, and it tells me what to cover next on this channel. I'm Dr. Richard James. Subscribe, because next week I'm covering the one vitamin that helps statins work better with far less muscle pain. That's the video that pairs directly with this one. Take care of your heart tonight. You've earned the conversation we just had.